Well, good afternoon. And we're delighted to see you here. It's a beautiful day outside. It's Sunday, and what you're going to learn in this session is going to make your choice very much worth it. So it's really my great pleasure and honor to moderate this panel, Global Ideas for U.S. Solutions to Advance a Culture of Health. And you recall that this morning, or some of you who attended the earlier session this morning, I described the culture of health, action model, our culture of health mission at the Robert Wood Johnson Foundation. I put up the culture of health action model. And I noted that there are 4 dimensions for the culture of health action model. I don't have the slide here, but the first one, action area 1, is shared value of health, interventions that build civic engagement, civic empowerment, social connectedness, well-being, and part of well-being. Action area 2 is cross-sector collaboration to create well-being. And you'll see well-being showing up in our work. It's a very global concept. We're proud we could adopt it. And you heard a lot about cross-sectoral well-being. Action area 3, we've done a lot of work in creating environments that make the healthy choice the easy choice, whether it's for healthy, affordable food, safe places to walk, bike, and play, and also address the really tough problems we face with residential segregation and other impediments to good health access for all. And the 4th area is an area that looks to braid together social services, healthcare services, and public health services. So we have an intertwined set of complementary healthcare services, more like what we've seen in the UK and in middle and high income countries in Europe. And they're doing a lot better than we are in terms of return on investment, health and well-being return on investment for their dollars. And across all of these dimensions, you will see and hear in our work a strong emphasis on equity and well-being. I just did a quick edit of what our presenters are talking about today, and I'm going to sit down in a minute because you really need to hear from them. And we've got all the action areas covered. So I'm just briefly going to go around, not in the, well, I'll go around in the order that you're presenting. So Olga Sarmiento is going to be presenting on work that she's done in Latin America and is now leading its application into the U.S., Global Innovations for U.S. Solutions on open streets and ciclovia as a way not only to get people moving, but also to build that social capital. So that's a couple of action areas there. Dr. Aboderin is going to talk with us about Sub-Saharan African perspectives on prospects for reverse innovation in urban health innovation. So you'll also see that not only are we hearing across our action areas, which have become fundamental, at least in my life, but also across continents. And Shamim, Talukder, and I'm not going to introduce each of these distinguished speakers beforehand, is going to talk with us about community interventions that advance community engagement in health and well-being in healthcare. And again, I talked a minute ago about how important that was to building a culture of health. That's the engine that gets us all started. And then we're going to go to Sandra Winter, who's at Stanford, and you can read the affiliations here. I did not do so. Working on citizen science interventions that actually sort of cut across some of the action areas and domains we care about, but they engage citizens. Again, you're hearing that citizen engagement to transform their communities and make them healthier. Rajesh Anandan from Sri Lanka is going to be talking with us about kid power. Stay tuned. And finally, we're really honored, Dr. Chu, to have you here with us from the Kaiser Foundation to give your perspective on what you're hearing about culture of health and on what it's going to mean for health and healthcare for all Americans, and what it's going to mean for Kaiser. And there has been, as I noted before, a paradigm shift in understanding of what the drivers of health really need to be, and health disparities and health inequities. So let's start with Olga, and each speaker will have 12 minutes to speak, and then there'll be time for a few questions afterwards. Thank you.
Okay, so thank you, Dr. Buffer, and thank you, Tracy, for the invitation. I really have enjoyed this conference. So I'm gonna go ahead. Which one is mine? This one. Okay. So today I'm going to talk about actually two programs. One is the Open Streets, but also I'm going to show you another transportation program that we have basically in the city of Bogota, and how that could be related with health. So first of all, I'm going to give you a little bit of the overview of these two programs, then I will go over the relationships that they have with physical activity behaviors, and I will end with some conclusions. So the first program is this one that you see here in this picture, is the Ciclovia, or the Open Streets program, which is how you call it here in the US. And this is basically a program in which we close the streets to the cars, like you see here in this street, and we open the streets for individuals so they can do leisure activities and they can enjoy a Sunday or a holiday. So this program has really expanded worldwide, and here we have in this map of the world that we have programs in on all the continents. Actually, we have a record of about 494 programs in 26 countries, but the highest concentration is here in the Americas. And within the Americas, we also have that 92% of the regular programs occur in Latin America. And this is what you see in this map of Latin America. But we also see in this graph that there is an expansion of these programs, almost like an exponential expansion that is happening in this century. And it resembles, for us as epidemiologists, like an epidemic. But probably it's a healthy epidemic, because not all the epidemics probably are bad. So this one, we see an expansion during this century. So I'm going to give you first a little bit of the characteristics of these programs in Latin America based on a survey that we conducted on 67 programs in 7 countries in Latin America. So these programs' characteristics are very, very heterogeneous. I mean, we have programs that go from 1 kilometer, like you see here in this graph, to programs like the Bogota program that has 113 kilometers. But 73% of the programs are less than 10 kilometers. So really are programs that can be adapted at city scale, neighborhoods, metropolitan, or at the city scale. And we also have a lot of variability in participants. They go from 40 participants to more than 1 million participants, which is what we have in the city of Bogota. In terms of opportunities for healthy behaviors like physical activity, we see that most of the programs occur regularly in Latin America, weekly or bi-weekly, and they also, given the time that they have this program, provide the opportunities for adults to meet physical activity recommendations, the 150 minutes, or for kids to meet recommendations of the 60 daily minutes that they are required. But in addition to that, these innovative programs, they have complementary programs that allow for more promotion of healthy behaviors, like physical activity classes, sports, or the route is also connected with other venues that could promote also physical activity, like parks, plazas, beaches, different places of interest for the public. So what evidence do we have of these programs? And here I will concentrate basically on the case of Bogota, which is the case that we have mostly studied. So the city of Bogota, which is about 8 million individuals, have this circuit of 113 kilometers, which is about 70 miles. Every Sunday and holidays, they open the streets, and we have a participation of 600,000 individuals to 1.4 million individuals, and we have a total 69 events in the year because we have a lot of holidays. So it's the 52 weeks plus a lot of holidays. And that happens during 7 hours. So in terms of some evidence, we have that those who are participants are likely to meet recommendations, and we here in this graph see that the estimates are pretty high compared to what we see, for instance, in the city of Bogota, the estimates, but we also see that for other cities that have this program. And here in this graph, you see the estimates for New York, for San Francisco, for St. Louis, for San Diego, and for Atlanta. So we see that there are higher estimates for physical activity recommendations. And in terms of the kids, we use accelerometry objective measurement to see what is going on with the children and participation of these programs. And we found that kids who go to the program are more likely to have higher minutes of moderate to vigorous physical activity, but most importantly, they have less minutes of sedentary behaviors. And here in this graph, what you see are a couple of estimates from population-based studies and intercept surveys that we have conducted in the program. And consistently, what you see here is that users, either adults or their older adults, are more likely to meet recommendations. But we also see an interesting interaction between leisure and transport. That's the last estimate that you have here. So those who who are users of the program are also more likely to bike for transport during the weekdays. And that interaction between leisure and transport leads me to the second program that I'm going to show you, which is our bus rapid transit system. So many of you who are here from urban planning and geography know that BRT is this system of transportation that is very innovative, that is cheaper than the metro, and it's also expanding worldwide. So I'm going to show you a little bit of the evidence that we have of this program that it's intended to be also multimodal to promote walking behaviors. So here again, we have the map of the world, and we see that the highest concentration of this type of BRTs is in Latin America. But the US, for instance, in this map, have at least 20 of these programs, and we know that there are more than 202 cities that have this type of program. And we also, as I show you with the ciclovias, we have an expansion of these programs in this century. Here in 2000, we have the program of Bogota that started and was modeled on the Brazilian program in Curitiba, but we also see an important expansion in high-income countries. So we also conducted a population-based study, and with objective measurements, with accelerometry, evaluated those who use the program and those who do not use the program. And the users are more likely to have higher minutes of moderate to vigorous physical activity, as you see in this graph. But then now the question that our policymakers, and we also as researchers ask is, what's going to happen with the expansion of this program? Are we going to continue walking, or what's going to happen? So here in this graph, you see two phases, actually three phases of the program. But most importantly, these are the projected phases. And look, all the changes that need to happen just for one phase. So are we going to continue walking when we have more of the system? So we conducted an agent-based modeling to see what could be projected in the future. And it shows that we're going to reach saturation. So if we don't think about density of other modes of transportation and distances between the stations, this benefit that we have right now is going to decrease with time. So the mayor of my city always says, to continue using public transportation and maybe walking, a developed country should be a place not where poor have cars, but it's where the rich use public transportation. So we really need to think what to do for those who use public transportation out of need and how we make that the choice in the future, because something that we do out of need that is good should be the choice in the future. So just to conclude, I show you two programs. One that is the ciclovia, which is for fun, for physical activity, social inclusion. But I also show you a program that it's the transportation program that also promotes healthy behavior, but probably out of need, and we have to think how to make that the choice. So lastly, I just want to end with another phrase of my current mayor who says, we build cities not for businesses or automobiles, but for children, and thus for people. Instead of building highways with restricted car use, We invested in high-quality sidewalks, pedestrians, streets, parks, bicycle paths, and libraries. All of our everyday effort have one objective: happiness. So right now we have that political will. It's good for promoting healthy behaviors, but when we don't have this political will, and we have had that in the last 10 years, you see that these programs continue. And that's because we see community appropriation of these programs and flexibility and adjustment when we don't have the political will. Thank you.
So we have a few minutes for questions, if you have questions from the audience. Olga?
Yeah.
I'm wondering about causation. So you talked about how the people who use these ciclovias also tend to be people who either bike to work or ride a bus and therefore walk more. But do you have a sense, I mean, I know causation is very hard to get at, but do you have a sense of which came first, if these were people already inclined to have a culture of health in their living, or that this sort of created that?
Yeah, that's a great question, because that's the bias that we can have. And this is a program of 40 years, so and we started evaluating it 5 years ago. So the only questions that we have used is, what would you do if the program was not here? Would you be physically active? Because we want to know if we have just already physically active individuals, right? And we have an estimate of 30% of the individuals who said, if I don't have this program, I will stay at home watching TV, and the kids say, I will stay at home playing video games. So certainly we have a proportion of individuals that probably will be active anyway, but we also have an important percentage of individuals that not. And also we have about, I think it's 25% of individuals that are overweight in the program. So despite they being active, probably being more active and probably having fun, it's gonna be good for their health. So, but causation is difficult. So that's why, like, the new programs in the US could provide us maybe a better design to see what could happen with these individuals that will start going to the program. So, yeah.
Is this program infectious?
I hope so. Did you see the
I mean, not just from city to city, but I mean, do people do it and then tell other people about it, get other people to come with them?
Well, I don't know. I did it's a mini analysis that I did with Facebook and network analysis with Facebook, and it looks like there are networks that are being created among these individuals in certain neighborhoods. So if you call that contagious, it's probably. And you see how, like, in this century, many other countries are doing the same program. So there's some contamination. It's probably a good one.
Well, thank you very much. And our next speaker is Dr. Talukder, and I would encourage people to think, as you hear these presentations, to think about that happiness piece that Olga mentioned, the social connectedness, the social networks that form, because that's another harder to measure outcome, and one that's very important. And I think you'll hear that in a lot of the presentations.
Thank you. I'm going to present a community-based intervention program in urban areas that is related to the health as well as the other services. This program, we are intervening in Bangladesh, in Dhaka city, as well as the other urban areas of different 5 more districts we call urban areas of Bangladesh. And in my presentation, if you look at that, the Shusti is a Bangla word that means the peaceful and pleasant, and we abbreviate it as a securing health through the safe treatment and other intervention. My presentation, I'm going to talk about what is the urban status in Bangladesh, then Shusti service design, and what the innovation and upcoming activities from the Shustis. This is a real situation in our country that we use rickshaw for our transportation, and a rainy day, this is the enjoyable time for our people. And if you look at that, what is the population? In Bangladesh, it is about 58 million urban population, which is about 34.3% of our total population. 1/3 of them lives in the slums areas, and 70% of them live in only one room with 48 per square feet per person areas. If you look at the education, 25% men and 32% women still don't have any education in slums areas. 62% of women and 1% men did not do any work in the last year. So it's about 38% women in the slums, they do work regularly. 90% of the slums people have the mobile phone, and 80% have the TV exposure in the last 24 hours. 47.4% income they spend for buying their food. It is, in general, all the data are taken from the Urban Health Survey 2013, but this last food expenditure that is from our household income expenditure survey, and that is a national figure, but in the slums areas it is more than 60% money they spend for food purchase. If you look at for the health status, 50% slums women received only antenatal care, one antenatal care. If you look at that, 4 antenatal visits, that is 29%. 67% slums women conducted deliveries till now at home. And diabetes is about 18% people, age more than 35 years, and 70% are not diagnosed cases. So they don't know that they do have their diabetics. If you look at that hypertension, that is 31% have that hypertension, and 21% reproductive age group women died for cancer. That is the highest causes for the reproductive age group women died in Bangladesh. For diabetics and hypertension, those have diagnosed, only 30% take the drugs for their treatment. And among them, 1/3 have a controlled diabetics and hypertension. In this situation, we started this intervention by engaging the community people. If you look at that, for each center, we engaged 365 people, 365, this is 1 year. So these 365 people are segregated, 15 people for a community management group. They are community leaders, businessmen, and other educated people. Then we included the small grocery shops, business shops, as a community business group. It is interesting that when we started the activities, then we thought that pharmacy may be one of the potential space for the referral system. But community people said that we used to go to the grocery shop daily, but pharmacy we go when we become the sick. So it's better to interact with the grocery shop for daily intervention, avoid them, as well as the referral system. So we included these 250 people. Then community entrepreneur group, we included 50 entrepreneur women. Those have diabetes or hypertension, or those have within the family diabetes or hypertension and interested to do some sort of small-scale business. Then community support group is the young people, teachers, religious leaders. That 365, and we started to make a promotional materials like annual calendar by these 365 people's face. That is some sort of owned by the people that this clinic, this service centers is their service center. And this idea we got from the community people too. We started by one center in 2010 in a traditional way to provide the healthcare services from the clinic as well as the satellite health camp within the community. Then we started second one because the first one financially it was not really recovered that, our expected amount of money. Then we started second one to see that what is the reason that it is not recovering the, financial expectation. And then we introduced the community management group. That was also failed. But as you know that, failure is the pillar of the success. On that basis, we decided to have 5 more clinics. And we put that information in our website and other promotional materials. And from 3rd, 4th, 5th, 6th, we started 2015. And then we started to apply in different research and program activities. We got a research work from a McMaster University for a clinical research, and that covers our 50% of the total 7 clinics cost. Then 2 more projects we got from US government, that is also covered 80% of the cost. And then these ideas like small shops, women entrepreneur, religious centers included for the awareness building and referral point, we introduced that time. And this year, we got a little bit of money for this research work. Then we introduced the laboratory, we introduced the pharmacy, annual health insurance services, new ideas, healthy food basket, and drugs bank. If we look at that, our whole service, then from the clinic we are providing the medical care services, laboratory services, pharmacy, as well as the referral services. Because the private clinic and other hospitals, laboratories exist in that community, we make a friendship with them. We say that, whatever service we don't have, we are going to refer to your centers. Please take the, reduced price from our beneficiaries. So they agreed, and we started to referral services in that point. Then if you look at that community service, that is healthy lifestyle service, I'm coming in that point in later on. Then beneficiaries card service, which is 3 different type of card: annual general health service, annual health insurance service, and annual corporate health services. Annual general health service is a 2 type. One is NCD health services, that card providing the special care for the NCD services. And for the ultra poor, there is 50% cost reduction. There is the ultra poor healthcare service card. And if you look at that health insurance services, that health insurance services is some sort of, we are giving that single member, then 2 member, and 6 member. The price for single member is about 9,000 BDT Bangladeshi taka. Then 1,000 taka is less if it is 2 member comes together. Then it is 3,000 less if 6 members come together by group. And we are giving the cash back when number 1 case, member is coming and he managed the 5 more members, then we are returning the cash money back to that member. Then in urban areas in Dhaka, we have lots of garments and small industries. So we started to propose these corporate houses, these annual corporate services. Then entrepreneur services, that 50 members, we are women, we're asking them, can you make a healthy food and sell it to the shops? So we make a link up with that, making the healthy food making and sell it from that, local shops. Then we are make a partnership with the bank, and bank is now going to give the money for buying the ambulance to that, women entrepreneurs, family members, or whoever interested, and that ambulance is now going to give a low-cost ambulance services for the people. And we also make a partnership with the bank that they will give the loan to the, if anybody is interested to make the pharmacy. So we started to make the pharmacies in the community level too. And moreover, in terms of our clinical research, we recently, from 6 months ago, we started to 2,000 household surveillance system with 17 different types of questionnaire, including health, demographic, and service sector survey. We also developed a partnership with optic fibers and broadband service providers in our country with an intention that we are going to give some sort of package free internet services for our beneficiaries. So they can order the services directly through the internet or mobile phone. Clinic and community service providers are equipped with now computer and tablet, so they can collect information instantly. If you look at that, innovative and ideas and intervention of upcoming activities, that is, as I said, that annual health insurance one family member to two, 2 to 6, his price is less. But as I said, that grocery shops also working as a referral point, and they're getting the referral fee. This healthy lifestyle basket is some sort of imposed to the health insurance, and that health insurance also covers the education scholarship for the children too. And if you look at the health insurance services, that is giving it health, the lifestyle basket, education for the scholarship, and reduction rate drugs and free facility delivery services of his family members. If you look at the drugs prices, how we are managing drugs prices and drugs selling. If someone wants to buy the drugs from our shop, then we say that there is no reduction prices from our shop. There is the MRP prices. But if you take the delivery at your home, then it is 5% less prices. If you give the order weekly and take a delivery at your home, then 6% less. If it is 2 weeks order, then 7%, and if it is 1 month order, then it is 8% less prices. And the women entrepreneurs, we ask them that they are just managing 100 drugs purchase people, those are diabetics and hypertension, because we are screening at the community, identifying that people, and they are communicating with them and selling the drugs to them for getting free drugs for themselves. This is a new idea that packaging of the food. As you know that in our, generally, we make our package for food like 250 gram, 500 gram, or 1 liter. The community people said that we need to pack it like 5 to 10 serving per day, monthly pack for 5 persons, including 1 diabetic patient, because understanding the nutritional value of a food, it is really difficult for the illiterate people or even for the literate people. So their idea, we are imposing in the packaging system and giving this type of packaging, and we are going to promote it at the national level. That package should be like this, that will give a nutritious values. People can understand I'll buy for 1 pack, 1 daily packet or 3 days packets. I'm going to finish. Our plan to make a 250 Shosti clinics, which will be established in the next 5 years all over the country. That will give some sort of sampling unit for the surveillance system. We started the APHRC, developing the APHRC system and DS mapping system for quality improvement and household and demographic surveillance system and policy direction of our country for urban health services. Shosti clinics also intended to publish different regular best practice and outcomes for the community engagement and intervention. In that ideas, these 9 clinics we have, we propose to give these 9 clinics names by our good friend, like Joe Buford Shosti Clinic, Elizabeth Macmillan Shosti Clinic, Hector Taraja Shosti Clinic, then Akhtar Hussain Shosti Clinic, then David Bob Shosti Clinic, Eugenics Shosti Clinic, Tony Capone. And last 2 months ago, I was in surgeon. I met with the surgeon ruler, and I requested him, can I give a name of Shosti by his name? He agreed, and he started to give us a lot of equipment for the cancer screening in our clinic too. Finally, Shosti need 260 more friends to provide technical support to establish a model which is sustainable. Is there anybody who are interested to be the friend of the Shosti? We are looking forward. Thank you.
Right. Well, thank you very much. What an impressive accomplishment. One question, if there's one question in the room, we can take it now instead of saving it for later. So okay, go ahead. Yes.
Because the Shosti products, I think those are for the slum population, as you mentioned. And the product level, most of the input or directions, etc., whatever the guideline written in English, probably Bangla would be a better way to reach out the population.
But you are correct. This packaging in Bangla, but we made it in English to understand this audience. But it is in Bangla, and all these products in Bangla. We started to develop our website in bilingual English and Bangla too. Yeah.
Could you just describe the government role in the clinic process of either financing the clinics or licensing or giving you support at all?
Interestingly, we did not get any funding for this clinic. We started without any money, but it is moving. It is extending 9 clinic, and like government is. I know that government is have a lots of problem in terms of providing the services in urban areas and good quality of services in different clinics too. Some of the clinic is not operating properly. And recently, government given UI that they want to give this type of unutilized clinic to the private sector or NGOs who was interested. So we discussed with them, we share our ideas and this model, and they asked us that we should apply for getting this clinic. We hope that we'll compete, and we hope to get this clinic and provide the services too.
Well, thank you very much. And at the end of this session, we'd like to know how to help. So our next speaker is Sandy Winter, and she's going to be talking about a really interesting citizen engagement project in building a culture of health.
Hello, everybody. As Tracy said, my name is Sandy Winter, and I'm from the Stanford Prevention Research Center, so I work just down the road here. And I'd like to thank Tracy and the conference organizers for giving me this opportunity to share about some of our work with all of you. So before I start, I just want to acknowledge that the collaborators we have working with us on these many projects that I'm going to be talking to you about. And I do want to highlight that Olga Lucia is one of our collaborators, and in particular thank her research assistant Sylvia, who's also helped to provide me with some of the materials for the slides today. We also do a lot of work with collaborators at different institutions here in the States. So I'm sure I don't need to belabor the point to this audience, but everybody here hopefully knows about the 3 risk factors, tobacco, diet, and physical inactivity, that are responsible for major chronic diseases in the world that account for at least 50% of global mortality. So addressing chronic diseases is a really important topic that we should be engaged in. And the work that we're particularly interested in is looking at how the environments in which people live, work, and play affects their ability to make healthy choices. And I'm going to ground my talk in the Culture of Health Action Framework that Tracy has been talking about previously today. So thinking about Action Area 1, which is making health a shared value, I'm going to be telling you a little bit about harnessing the power of citizen scientists and the approach that we have there. And then thinking about fostering cross-sectoral collaboration, I'm going to tell you about the ways in which our citizen scientists collaborate with others to advocate for improvements to their neighborhood environments. And then in thinking about creating healthy, equitable communities, I'm going to give you some examples about some of the solution-oriented approaches that our citizen scientists have come up with. And then in terms of the last action area, strengthening the integration of health systems and services, that's something that we haven't delved into too deeply at the moment, but it's certainly an opportunity that is awaiting further research. And I have to say that some of this sort of bucketing under these different headings is a little bit contrived, because a lot of the work that we do cross-cuts across all of these different sectors. All right, so Action Area 1, making health a shared value. So our citizen science approach really looks at a triad of citizen scientists who are just regular community residents who live in the neighborhoods that we study. And our community residents range in age from 10 to 92, so it's an intergenerational approach. And then we also partner with public and private sector individuals, and then we have a research component because we're from Stanford. And we combine this with a mobile technology, so it's a technology-enabled approach, and it's very much about community engagement. And the whole point of this is to build community capacity to drive neighborhood environmental improvements. And so how do we do this? We have developed an application called the Stanford Healthy Neighborhood Discovery Tool, which is a really simple tablet-based application that's used by residents who go around and they do neighborhood assessments within their communities. The application is really simple, but to design an application to be really simple, it takes a lot of thought and a lot of iteration, and we involved our citizen scientists in the approach right from the very beginning. So we didn't do it as researchers and then just test it out on them. We worked with our community residents right from the very beginning stages of designing the application. So this graphic here shows that the first thing they do is they take the tablet and they go for a walk in their neighborhood, and they choose where it is that they want to walk so that they can tell us their story. And then the first slide that you will see on your left-hand side, you'll see there's some headphones. So there's some audio instructions that can be tailored to different languages that tell people what it is that they're going to be doing. So very limited amount of text, because this application is designed to be able to be used by people who have low literacy and low technology capabilities. So they get some instructions, and then they go for a walk around their neighborhood. They take pictures and they record audio narratives. So for every picture, we like to have them say, I took this picture because, so that we don't have to interpret what the picture's about. So they take the pictures, and then there's an opportunity for them to review the images, and then at the end, there's a 25-question survey that can be tailored towards different applications. So right now it's pretty focused on the built environment, but you could have a module that focuses on food access or parks or fall prevention in the home. I mean, there's all sorts of applications for this particular kind of approach, so it's very flexible. So here's one of our citizens. They go out, they gather photos, audio narratives, there's the survey that I've mentioned, and then also there's a GPS-tracked walking route. So those are the kinds of information that we gather. And then we go through, so the technology is just a launching pad. It's not the be-all and end-all of our study. Once the citizen scientists have gathered this information, we go through a process where they collectively review their information together, and they discuss it as a group. And the idea is for them to prioritize issues that they want to address in the community. And we try to structure this in a way that it's both feasible and important, so that sometimes they might want to build an overpass across a road, which might not be a feasible option, but there may be other feasible alternatives that they can look at. And so we really try and stress a solution-oriented, feasible approach. And then we brainstorm solutions. So we don't want our citizen scientists just to come up with a laundry list of things that they are unhappy with. We want them to be part of the solution. So a very important piece of this is brainstorming solutions. What kind of things can be done? And often this falls into two categories: things that the community can do themselves, and the other category would be things that they need to partner with bigger organizations like Public Works or something like that. Once they've brainstormed solutions, we also help them to think about potential partners. So often it's the case that there may be more than one person or one group who's interested in making improvements. So for example, if you improve a neighborhood to make it more age-friendly, that often is improving for women with strollers or people with disabilities. So thinking about the different potential partners that might be able to help them. So once we have had our citizen scientists gather the data and decide what the various solutions are that they want to implement, the next piece really is thinking about cross-sector collaboration to improve well-being. So these pictures show some of our citizen scientists voting on some of the issues and discussing some of the issues, and this was actually in the US in North Fair Oaks, which is a predominantly first-generation migrant community with people from Mexico. And what we do during these meetings is we also train our citizen scientists to be advocates so that they can present the data that they've collected to different stakeholders. So some of these stakeholders could be public sector people, like people from the Department of Public Health or Public Works. We've involved mayors and things like that. It could also be some people from the private sector. So often trash or litter is a problem that prevents people from walking. And so maybe partnering with a waste management group to find out how the neighborhood can be cleaned up a little bit might be a good option. And then also we often work with coalitions, so things like bike coalitions or community activist groups. So this is the idea of this cross-sector collaboration. And we feel that this is a really sustainable model for trying to drive neighborhood change, because we're connecting our citizen scientists with people in the community that can help to drive these changes. And then thinking about cross-sector collaborations, this is just a map of some of the places where we are either doing work or where we have work planned. And we work with researchers and institutions all around the world to try and improve global health. So then thinking about action area number 3, creating healthier, more equitable communities. So I'm just going to talk a little bit about some of the projects that we've been working with. So I'll start with Colombia, seeing as Olga's here. So really in Colombia, I think the discovery tool has been used to increase awareness. So it's a new perspective. So some of the comments from the participants is that they've grown up with the cyclovias in their environments. The cyclovias, as Olga says, have been going on for 40 years. And so for some people, they can't even imagine what it would be like not to have the cyclovia. And so for them to be thoughtful about thinking about all of the benefits that the cyclovias provide in terms of equitable access to physical opportunities for people across age spectrums, income spectrums, it's really been able to provide a fresh set of eyes. And then thinking about policymakers, the cyclovia has been operating in Bogota for 40 years, and so being able to assess the program using a new kind of approach may be able to provide new insights to policymakers. And then the model that we have for the cyclovia, we are replicating that design model in Chile, in Colombia, and in a number of places here in the States. And so hopefully we're going to be able to make comparisons across countries and across cultures. And so as I said, when people compared, so this is the discovery tool users, when they compare the cyclovia when it's there and when it isn't there, you can see at the bottom there's pictures of the road with just lots and lots of cars, or alternatively during the cyclovia time when there's lots of pedestrians. And so the participants said that using the discovery tool process helped them to increase their perceptions about neighborhood safety. And we found that in Bogota and also here in San Francisco, but the magnitude of change was much bigger. So in Colombia, having the cyclovia really, it was felt to make a big difference to safety compared to the responses from the people here in San Francisco. And it also increased participants' awareness about how public spaces can be revitalized and energized. And then it increased their appreciation of the inclusiveness of this kind of approach to promote physical activity opportunities for everybody. And the citizen scientists felt empowered, which is a theme that we hear again and again. So one of the quotes from one of the participants was that this provides an opportunity to conceive ideas of change to improve the quality of the spaces in the city. So then just thinking about Mexico. So Mexico, the policymakers are not as accessible to the citizen scientists as they are in other places. And so because there was this inaccessibility to local policymakers, the participants came up with some social mobilization solutions. So here you have some of the group of the citizen scientists that we engaged with in Mexico. And so some of the things that they spoke about were things like having community campaigns to make sure that people leashed their dogs and cleaned up after them, because dogs on the street is an impediment to physical activity in many cases. And also there was this great intergenerational discussion about what some people thought was graffiti and other people thought was street art. So it seems that some of the teenagers in the group were painting what they thought was street art, and the older adults thought it was graffiti. And so this lovely conversation came up about how we could think about opportunities where the young adults would have an opportunity to express themselves artistically in a way that wasn't offensive to the older adults. So these kinds of intergenerational conversations can be very useful. And then we've also done this project in Israel, and here I would say it's about bridging cultural divides. So we worked in both Arab and Jewish Israeli neighborhoods that had varying degrees of socioeconomic status. So the Arab neighborhoods in particular were quite poor, but the thing about it is that they all shared certain thoughts and feelings about the locations in which they live. So often the problems are similar across neighborhoods, and everybody wants to live in a neighborhood that's conducive to health and well-being. And so even though there were different religious views, different socioeconomic participants, they all had this common idea that they wanted to improve where they live for health and well-being. And so some of the things that they did is they came up with some senior-friendly walking routes, and they created this map, which is called the Golden Path, and this is now being publicized at the Haifa Department of Tourism. And then here, they also formed walking groups. So the person who's standing there in the black outfit is the mayor of Haifa. So he totally got behind this. They've organized classes and all sorts of things. And this project is going to be replicated in other in other cities in Israel. So just a quick example of something just to show that we do also do work in the US. We had, this one I would say was some examples of a built environment change. So we did the Discovery Tool project in a low-income housing site in North San Mateo County. And after we'd finished doing the project, the citizens came and asked for additional advocacy training. So we developed an additional program, and here's some of the citizens with their certificates to say that they'd completed the training. And then after they'd had the training, the citizens convened a forum of multi-sectoral policymakers. So you can see here all of the different policymakers. And the citizens presented their concerns to these different policymakers. And within 4 days, they were able to achieve some fairly simple built environment changes to do with painting the sidewalk and the fire hydrants to make the neighborhood safer. And that's pretty quick, 4 days. So just thinking again about the culture of health framework, the promise of this approach is that it can really help people to articulate their priorities and values bilaterally. So it's not only the citizen scientists, but the policymakers, the researchers can have an opportunity to engage in important dialogue. And this creates mutual understanding in a collaborative environment, and it provides a mechanism for engaging residents, local organizations, and policymakers together about the issue. And it also allows residents to be part of the problem identification and the solution building process, which we think is very important. And it provides a voice to those who might be marginalized. So often we do this project among older adults, among teens, among low-income populations. And so as we think about moving forward, the opportunities we think exist to better understand the flow of communication, the influences that are different, the advocacy and the impact that differ by different communities and cultures. And we're hoping to be able to inform and to include technology-enabled processes to help to reduce health disparities. And we're very interested in this idea of an intergenerational technology-based approach. And also we think that there's many opportunities to partner with the private sector as well as community organizations. That's all I have to say.
All right.
Thank you.
Is there a question? We'll get one question in now, if there's a question.
So I think that's a great idea, and we're definitely working with our developers currently to try and improve the Discovery tool and take it off a tablet so that you could use it with a smartphone. The thing about gathering GoPro and video information is that it becomes quite difficult to analyze it. You end up with tons and tons of data, and the data recognition software packages are not really at that level yet where the process of analyzing that kind of information can be automated. So often you would need somebody to sit there and review all of the videos. So we found that having people review the photographs helps them to increase their awareness, but it's manageable in terms of the scope of how much time is spent doing that kind of activity. Thank you.
Thank you. To be continued, and there are a number of recurrent themes. I wish I could sit in the audience and just really drink this all in without looking at time and so forth, but these are all really exciting presentations. Huh? Bring everybody else down? Well, Beth, can you see this one?
Yeah, sure.
Oh, okay. Okay, and I can see them here, but please feel free. Okay. Rajesh is going to talk with us about kid power.
Okay, thanks. So I'm Rajesh Anandan. I run Unicef Ventures, which is a incubator that launches new digital businesses in the US that support UNICEF's work for children around the world. So I want to tell you about a program we launched in the US and we're scaling it up very quickly that aims to solve two global problems by nurturing a desire that all kids have and using the world's first wearable for good. But before we do, I want to start with a video that in a way embodies what culture of health means to us. And this was a video from Atisha, a fourth grader in DC who's part of Kid Power, and her grandma that they sent in to us.
Good morning. Happy Tuesday. It's the top of our day. We're out at 5 a.m. this morning trying to reach a goal of 10,000 steps.
Good morning. We already have 6,000 steps. We're trying to get to our goal.
Yes, yes, yes. Be very mindful of your health. It's your responsibility to nurture and develop your own health.
Because if you don't, that's bad.
Have a great day. Peace.
Peace.
So I don't know about you, but I do not have 6,000 steps on my Kid Power band at 5:30 in the morning. So we started with a challenge in a faraway place. As UNICEF, we work in 190 countries. A lot of our work focuses on health as well as education, et cetera. 1 in 4 kids across the developing world are malnourished. And malnourishment is now the #1 root cause of preventable child deaths. About 3 million lives are lost every year from malnourishment, which is not okay. And we know what needs to be done. Now, some of the issues are harder to solve and require us to address social norms, agricultural practices, but there are others that are actually quite easy to fix. So the most extreme case of malnourishment, severe acute malnourishment, is a medical urgent condition that requires treatment, and it's treatable with one of these things. It's a ready-to-use therapeutic factor. It's not sustainable, but it's like when you go into the ER, you don't want a sustainable solution. It just costs 40 cents, and 5 of these a day, 4 to 6 weeks, a child will go from severely malnourished and about to die to running around healthy, and there's a 90% success rate where kids don't actually get malnourished again. But we don't have funding. We know what to do. Meanwhile, in the US, we have a very different issue. 1 in 4 kids are sedentary, completely inactive. 2 in 3 are inactive and not getting the level of activity they need. And physical inactivity and obesity are now the top concerns for American parents. And we know what needs to be done. This is not that hard. Exercise more, eat better. And in this case, we have the fiscal space in this country. There's a $350 billion philanthropic market, 95% of which stays right here. But money is not the problem, and we haven't solved it yet. And so the grown-ups have failed to solve both of these problems, and as UNICEF, you won't be surprised, we do what we always do, we put the kids in charge. And so we started with a simple insight, which is that helping others fulfills a deep desire that kids have, and it helps them feel significant and important and valued. And we use a shorthand for this, which is that all kids have an intrinsic desire to do good. It's not really to do good, it's to feel important and valued. And we've built a different kind of tech-enabled PE program for classrooms and a retail business off of this one insight, and it's now been a couple years and it's scaling fast. And so it's a very simple platform. This is a Kid Power Band. Kids get active, they earn Kid Power points. It's very basic technology, accelerometer, pedometer, it tracks your movement, and it has a little display because kids love displays. As kids get active, they earn Kid Power points. Every time I earn a point, it vibrates and it scrolls a little message that says, "You're awesome." That these points actually unlock a packet of food. And can I see a video of the person who's delivering this program in Haiti? These are the 8-year-olds. So the reason this works is that we're tapping into something very deep-seated with kids. It's an intrinsic desire. It's not like prizes and rewards and the technology that wears off. This is something that's sustainable. And so as we've started to scale the program, we hear all kinds of stories about how kids and families in schools are actually using Kid Power. All we've done is solve for why. The kids are coming up with the how. So, we heard about the kid, the third grader in Boston, who started taking the stairs every day before school. She ate breakfast early so she could take the stairs to earn more points to unlock more packets. We heard about an elementary school whose fourth graders started a walking club all by themselves so they could earn more points and unlock more packets. We heard about a girl who insisted that her mom take her for walks after school in the park every day so she could earn more points and unlock more packets. And so we've had the program in our schools independently evaluated a couple different times. And these aren't RCTs, but they were, the baseline, the control group was essentially a group of kids in a similar kind of geography and context with the technology without the purpose. So it wasn't actually a baseline. So the technology wears off, the novelty effect wears off in a couple of weeks, and then it doesn't really matter. Purpose does not. So what we've seen is that kids are 55% more active. We've seen that kids reach their MVPA daily recommended kind of activity levels 30% more days. And we've delivered the solution to a classroom in a way that's easy to use and plug and play, so most teachers want to keep doing it. We also launched a retail product, which is a very different business, and the way in which success is measured there is different. We were able to do it thanks to Target and Star Wars, who are our kind of presenting partners. We sold out of the product in one day. And then in December and January on Target.com, 4 of the top 10 selling wearables, not kids' wearables, wearables, were Kid Power bands. And at this point, families who are using Kid Power are using the app 2.5 times a day. We've embedded wellness and philanthropy into these families' daily lives. So our goal is to reach 10 million kids. This may seem outrageous, but we went from 100 to 1,000 in 6 months, from 1,000 to 10,000 in 6 months, from 10,000 to 100,000 in 12 months. We're going from 100,000 to 1 million in the next 12 months, and we'll go from there. And if we do that, we'll also save a lot of lives. And so for us as UNICEF, as we think about RUTF, today the world's largest donor is USAID. By 2020, it will be a bunch of 8-year-olds. And we know that we can do this because of Atisha and her grandma and what they've shown us in terms of what they can do and what they're able to do if we just let them know why. Thanks.
So again, we have a few minutes for questions. Another really extraordinary presentation. I saw a hand in the back.
Yeah, so it's an accelerometer and a pedometer, so it's not just walking. It's like most other fitness trackers. It does get challenging though for kids who, let's say, can't move their arms. And so in our classroom program, teachers can manually add points to kids who are, let's say, they can't move or they're not able to move, but they're contributing in their own way.
One more question.
Hi, thanks for that. I work in South Africa, and childhood obesity is an emerging and actually untethered epidemic. So have you considered, and then this is not just an issue in countries like the States, have you considered how this kind of intervention can be applied in other settings, other low middle-income country settings where we don't?
Yeah, so, as UNICEF, We're getting requests from our colleagues around the world for, like the Ministry of Health in Mexico wants to figure out if they can bring this in. Singapore, which is a very different market, Indonesia, et cetera. The problem is the price point. So in our current price point is around $40 per student for the school year, which includes a tablet for the classroom, a band for every student, the cost of the impact, weekly curriculum, lesson plans, digital dash, all that stuff. Anyway, that's okay for a philanthropically funded program in the US. It's just untenable when we get to a low or low middle income country. So we're starting to think about how do we adapt the program so that it doesn't require as much hardware. The challenge is, part of the reason it works is the real-time feedback kids get. So having a display, having it vibrate and scroll a message 5 times a day makes a huge difference. So we haven't solved it yet, but it's an important one.
I see so many other questions in the room, and I also see that we have 2 speakers. So what I'm going to do is to ask if you can hold your questions, and let's hope that our phenomenal speakers can spend a few minutes with us here afterwards for follow-up questions into the break that follows. So I'm delighted to invite our last presenter, Dr. Aboderin, who's going to be talking with us about prospects for reverse innovation. Thank you.
Thank you very much, Chair. Ladies and gentlemen, it's a real honor for me to be here today and to be able to share with you some perspectives from Sub-Saharan Africa about the prospects of reverse innovation to advance urban healthy aging approaches in the US. My talk today will have 2 components. First, and by way of providing a context, I'll sketch very briefly what we know about the possible scope of such reverse learning from Sub-Saharan Africa to advance health systems development in the global north broadly. And then I will explore in some detail what concrete opportunities and what potential might exist for such learning from Sub-Saharan Africa to advance specifically urban healthy aging approaches. So to jump right in, I think there is a growing recognition that health solutions forged in low-resource Sub-Saharan African settings may inform health systems development in the global north. And in this context, particular emphasis has been placed on approaches to mainstream and refine community participation, mHealth applications, and to increase the responsiveness to marginal populations. So the question is, what scope might exist for such reverse learning, also for advancing urban healthy aging? And a look at the contexts within which aging is unfolding in Sub-Saharan Africa suggests that there are 2 perspectives in answer to this question. The first is that at the moment there might be no immediate or concrete opportunities for such reverse learning. And this is simply because no concrete urban healthy aging solutions or models have been developed in Sub-Saharan Africa or have been tested so far. And this gap reflects salient demographic, policy, and health sector realities in the region. The major demographic reality, as many of you are aware, is the overwhelming youthfulness of Sub-Saharan Africa. About 80% of the population at the moment are aged below 35 years, and this makes the region the youngest globally. A corollary of this is that population aging in Sub-Saharan Africa is only incipient, so the share of older people in the population is going to remain below 10%, well beyond 2050. This graph just illustrates this trend for Sub-Saharan Africa and underscores the contrast with other developed and developing regions where proportions of older people are already much higher and set to rise much higher in the next decades. The demographic realities have very much shaped the policy realities in the region. And these are that older adults remain relatively invisible in mainstream health and development strategies and debate. And the extant regional or national aging policies that are there offer very little direction or frameworks for action on urban healthy aging. And this policy reality in turn is reflected in current health sector realities in Sub-Saharan Africa. there is a continued priority focus on the health needs of children, youth, and reproductive age adults. And our current experience with the El Niño and its aftermath in Eastern Africa has shown that these health challenges are bound to be exacerbated by the effects of climate change. At the same time, whatever non-communicable disease agendas are emerging in Sub-Saharan Africa remain very narrowly conceived, and they omit key old age-related concerns. And of course, the health sectors are constrained by severe resource and capacity limitations. This table just gives you a flavor of the extent and the depth of these capacity limitations, as well as the health challenges in lower age groups. The second perspective that I would like to share with you is that whilst there are no immediate concrete opportunities for reverse learning from Sub-Saharan Africa, there is clearly an emergent potential for it. And this arises from the fact that there is a great likelihood that we will see in the coming years an emergence of urban healthy aging models in Sub-Saharan Africa, models that might be relevant for the US or for the global north more broadly. And this likelihood arises, I would suggest, as a result of three features of the demographic and policy context in the region. The first feature are the trends in the absolute number of older adults, not the proportion in the population, but the absolute number. 46.5 million older people already live in Sub-Saharan Africa. That's double the number in Northern Europe. And this number is projected to rise more rapidly, more sharply than any other age group or of any other region in the world. So by 2050, we'll have about 161 million older people in Sub-Saharan Africa. That's 40 million more than in North America. And the growth in the number of older people is going to be most marked and most rapid in urban areas. Data we have from Kenya, for example, shows that between 1998 and 2008, the number of older adults rose by 55% in urban areas versus only 2.3% in non-urban areas. Within this context, one can detect what one could describe as a growing impetus to pursue action on urban healthy aging. In the policy arena, we've seen this year the adoption of the African Union Protocol on the Rights of Older People, which includes a large section on health, and which will be legally binding once it's ratified. At the same time, the WHO Africa region is developing a regional strategy on aging and health to concur with the global strategy on aging and health, which will be adopted later this year. And several countries, such as Kenya, are planning national strategies on aging and health. In parallel, there is an incipient recognition in some countries, like Kenya, and specifically Nairobi, of aging and issues of older people in urban strategies for social welfare and health. And then finally, we are seeing an increased engagement by research and civil society actors in the field of urban aging and urban and health specifically. And the third and last, and I think very important feature of the current context of aging in Sub-Saharan Africa is the ethos that seems to underpin the thinking about forging responses to aging. The first element of this is that there is a sense that this is a blank slate, if you like. Sub-Saharan Africa has the opportunity to forge entirely new systems and therefore an ability to avoid the mistakes or the perceived mistakes that have been made in the global north. And very much linked to this, there is an emphasis in Sub-Saharan Africa on the need to develop homegrown solutions, building on African values and strengths, and not simply copying Western models. And this emphasis is very much resonant with, and I think inspired by, the African Renaissance paradigm, which is founded on a critique of Western development models. And this quote just expresses this. African Renaissance means not blindly copying everything European, or you could substitute US for that. In this context, let us consider some of the most distinctive aspects of Africa's identity. And one of those is that in Africa, Old age is given great respect, and so too are parents. So within this context, I'd like to draw your attention to two current initiatives that are beginning to take forward the development of urban healthy solutions in sub-Saharan Africa. The first is an initiative towards the development of long-term care systems for the region. Based on a recognition of severe deficits in the customary mechanisms and systems of family care, there is now an endeavor underway to design long-term care mechanisms that are compatible with African values of family solidarity and that harness communities. And in this respect, a regional dialogue between policymakers, practitioners, and researchers in December this year is going to discuss and try and pinpoint principles, directions, and models for such long-term care systems. And at the same time, at a much smaller scale, and in a small-scale research to innovation project in conjunction with the Nairobi Living Lab initiatives is trying to develop local long-term care solutions and then lead them to proof of concept testing at the end. The second initiative, also in Nairobi, is one that is trying to develop an age-friendly slums initiative. Work so far has shown that the existing age-friendly city framework that was developed by the WHO only partially captures older slum dwellers' priority concerns. And there is a need for an incorporation of additional concerns to additional domains, to capture these concerns. One domain is that of basic quality of housing and sanitation facilities. Another is that of local governance. And the third, perhaps most important, is that of intergenerational strain between older and younger generations, very much engendered by the prospects, the lack of economic prospects for children and youth. And this is something that is of utmost importance to the well-being and the health of the older slum residents. So based on these insights, we are trying to develop an age-friendly slums initiative in Nairobi. And this image just gives you a sense of the people, of the environments that are involved in an age-friendly slums initiative. So what are the implications that one could draw from the perspectives that I've shared with you? Well, I would suggest there are two implications. The first is that I think there is definitely a value in exploring and pursuing opportunities for fostering joint Sub-Saharan Africa US learning on urban healthy aging. And the second is that the current initiatives that I sketched on long-term care and on age-friendly slums may offer an initial focus for forging such engagement. And with that, I'd like to end it, and thank you very much for your attention.
Before we go to our distinguished discussant, questions for this distinguished speaker, one or two questions?
In this country, one of the Hispanic caucus members, Congresswoman Grisham from New Mexico, who was the Secretary of Health, has actually introduced a bill developing a Peace Corps type caregiver program for long-term care. A problem that we have is that nobody wants to fund it. But I just thought I could comment on the caregivers and what you think would be the solution on how to provide an incentive for caregiving. And this model is to provide young people college vouchers for tuition to go to school.
Okay, that's very interesting, and the question you raise about the incentives and the motivations for caregivers is a very critical one, and I can't say that we have found any solutions yet. But what seems to be clear is that the caregiver corps needs to be community-based, and in the slums that we've been working with in Nairobi, there is a sense that an intergenerational model where youth who are out of work and who don't have any prospects might well engage in such caregiving activities. How to fund this, how to retain the interests of this youth are challenges that we need to address, and we will do that. Yeah. Any other?
Well, thank you
No, I
again.
think that's it, yeah.
And we'll take questions at the end. Thank you very much. And now, Dr. Chu, we would welcome your comments. You can stay
Great.
there, you can come here. Dr. Chu is the Executive Vice President of the Kaiser Foundation Hospitals and Health Plans, and I'm sure has reflections on these multidisciplinary and multi-component interventions that we've heard about. Dr. Chu.
Great. Well, thank you very, very much. I hope you don't mind my staying here. A little easier to thumb through some notes. Actually, I want to just congratulate everyone for really incredible presentations. And I think one of the things that all of your presentations point out is that, and I was actually asked to comment on how these models might actually teach us, teach the U.S. on how we might import solutions that could be applicable to our system. But I think first and foremost, I actually think that it points out a real framework issue that we have in the United States, right? So, we're talking about trying to advance a culture of health, but really when you think about $3.2 billion and how it's spent in the United States, it's really about the culture of health care. It's not culture of health, it's a culture of health care. And you might think that, well, what's the difference, health care, but it's a world of difference, right? Because it's a framework issue. It's about how we actually emphasize medicalizing health as opposed to looking at much more community solutions and looking at the intrinsic motivations, whether they're kids or citizen, we could call them citizen scientists, and others who are invested in trying to figure out what might be the best solutions for the community. Instead, we sort of bring them into big medical centers, academic medical centers, hospital systems, and we think that by interfacing that way with our population, that ultimately the health of the population will be better, right? And in many ways, when people are sick, you really need that. But if you think about what are the drivers of health in a culture, in a community, it's not really that, right? Because I think the best definition of culture that I've heard is it's what people do when nobody's looking, right? When you think about it. And how many people live a healthy lifestyle when nobody's looking? And how can we in the healthcare delivery system think that because we told you should be doing this, eating healthier, watching out and exercising more, that you're actually going to do it, right? It's just not conceivable, especially since, the average, I don't know the statistics, but in the US, the average citizen actually sees a doctor, if they see a doctor at all, an average of 4 times a year, right? So it's 4 visits a year to a doctor, and right now the average visit is 13 to 15 minutes, basically. So it's 1 hour a year to interface with every citizen in the United States to try to instill a wide culture of health, and that is actually a tall order. And of course, I think that one of the problems that we face in the United States is that we've fooled ourselves into thinking that this paradigm is the way to go. And in fact, I think what all of your presentations point out is that it's not. It's not because I don't want to put it really starkly, it sort of infantilizes the citizens. It puts citizens in a dependent atmosphere, and it doesn't really build in those motivational aspects that you're talking about, the engagement aspects, and really the pure joy that I think you're talking about, where kids have, you're actually feeding into the intrinsic joy of people in relishing in their lives, right? So I actually think the paradigm has to shift much more. And one of the things that we've been talking about at Kaiser Permanente is this notion of life integration. I think you'll see that in some of the, certainly Olga, I see that in what you've been doing in Bogota, and the idea that, building these events around an environment that encourages people to be active, and not only encourages, but where they begin to expect, right? I mean, you have 69 events, but you also have lots of different avenues of trying to make sure that people use physical activity in their everyday lives. It's really about, building in that expectation that healthy behaviors is integrated in everything we do, right? So just the transportation to and from work, or the early walk in the morning, 5:30 in the morning is a little excessive for me, but you notice that the granddaughter was walking with her grandmother, and that was amazing, right? Because you get kids involved, and all of a sudden they hound the parents to death, and you have to cook better, you have to exercise. So it's really about building that sense of what it takes to integrate healthy behaviors in all of your lives. I think that in the Bangladesh example, what I took out of it were sort of all these interesting behavioral economic approaches to, incentivizing people. I don't know, I have funny feelings about behavioral economics. I'm sure it's true, by the way, that we can actually incentivize people, for a variety of reasons to act a little better or behave or engage in activities that are healthier. But I always feel like, there should be a different way of doing it, right? Sort of like, that's why I like, these kids and their sheer joy in doing, in actually getting something done that's healthier, right? Rather than thinking that I'm gonna get this if I do that, or my premium is gonna be lower because I live healthier, or my premium is lower if I don't smoke, right? Which is a very controversial thing. Of course it works because, it gets people to behave healthier for economic reasons, but you sort of would like people to want to be healthy because they want to be healthy, as opposed to because it's going to be cheaper for them in some way. I love this idea of citizen scientists really teaching people and giving them a tool to looking at what they could be doing to make their environment or their lives healthier, right? That's basically what you're doing. You're giving them a tool that allows them to see the world and also gives them an analytic tool where you're helping people with analysis and helping people think through what's actually possible, right? And I think one of the things that we've done in medicalizing health and healthcare is that we've taken that away from people, right? People don't really see, what can I really do in my environment, right? What can I do to be very active and activist in order to participate in this joyful way of being, creating a community that's healthy, that's respectful of the aging population, that's also respectful of children growing up in that way. So I actually think that there's a lot to learn from, all of what you're proposing. I think it has to start with how we approach health in this country. It's got to be a more balanced picture than healthcare, right? You think about all of the dollars that we spend, $3.2 billion, and we're not really that healthy in a way. Getting people to exercise is like, well, pulling teeth. But I do think that New York is a good example. I know Mike Bloomberg, got a lot of heat from a lot of communities for building bike paths and narrowing Fifth Avenue so that people can actually bicycle to work rather than And in New York, by the way, you have to walk a lot in New York. All those steps up and down the subway system and wandering around. You can't drive anywhere in New York. But the idea that now you have the avenue to bicycle to work, right? And I love the city bike share. I mean, it's actually City Bike in New York, but many urban communities are now developing these bike share programs that encourage people to use it as a mode of transportation. I love those ideas. And I think that, if we begin to think about those kinds of built environment, and by the way, the other thing is the overall, even in urban U.S. cities, there are huge food deserts, right? People not able to access good nutrition in a way. And I actually love this idea of, getting people to walk and getting something for it, and getting the feedback for it, right? And I'll give you an example. 11 years ago, when I came to Southern California, I don't know if you don't know, Southern California, but South LA is where the Watts riot was, and it's where there are really socioeconomic challenges. And 11 years ago, we had 200,000 members who lived in SPA 6, or Service Planning Area 6, which is South LA, and we had no doctors in that area, zero medical office buildings. So we made people come to our fortified medical centers in, believe it or not, in West Los Angeles, or in Bellflower, and that was, the people who were probably least likely from a transportation perspective to be able to access care didn't have access within their neighborhood. So, what we've done in the last, it hasn't finished yet, but the plan is to put out 3 large medical office buildings. We finished one 5-6 years ago in South LA. We broke ground on an 80-doctor office building in Baldwin Hills Crenshaw, and then the last phase will be one in Watts. So we'll actually have a delivery system that matches the membership. But more important than that is when you put a medical office building in a community, how can you leverage the other community partners to actually help? So one of the things we're doing is we're bringing the Bank of America has agreed to put a part of their banking headquarters near where we are, where a couple of restaurants are beginning to open up. And you begin to leverage community resources in sort of a citizen scientist way. You could probably, we didn't do citizen scientists, but we actually did a lot of video ethnography with members of the community who told us about a lot of the things that you probably are picking up in your activities. And it opens your eyes to what you could be doing, right? Safe walking paths to school for children. That's another way of integrating physical activity for kids. Because you think about a place like South LA, first of all, LA is so big, everybody drives everywhere, takes buses. But if you had a safe walking path and you can get parents to walk their kids to school, that's a win-win, and that can be integrated every day of the week, right, as long as there's school. So I think that's the lesson I get from all of what you're saying, that it really is about engagement, it's about motivation, and it's about fundamentally reaching down and finding what fundamentally is joyful about health and healthy communities. That's what I got out of this session. Thank you.
Well, thank you very much. I think this session in many ways, from start to finish, has been transformative. I'd like to thank, is anybody in the audience, please stand up if you were involved in any way in putting together this session. Come on, Joe. You did a great job. I think you ought to come to the Robert Wood Johnson Foundation and present your work there. There's no way I can bring back, and it looks like you're going to agree. That's right. There's no way I can bring back the meaningfulness of each of your presentations. What it gets at is the value and meaning of social connection to one another, the altruism, the energy, the caring that went into each of the interventions, each of which developed a new system of healthcare or is looking to do that, and each of which harnesses the power of human caring and human connection. And when we think about, as I mechanistically put it, Action Area 1 and so forth, when we think about what really drives a culture of health, it's heart. It's heart and determination, and it's probably heart in a number of ways. You want a strong and healthy heart, but I think we heard the heart in each of your very ambitious projects and undertakings, and I, for one, want to stay in touch about how all of them develop. So I think if I were in the audience, I would give you all a standing ovation for your contributions today. Wonderful.